Hello teammates, I'm Dr. B and this is Nate, and the objective with this video is for a visual inspection of the shoulder. We're going to be following the lines and orientation of Hoppenfield, the textbook. Our purpose, that's the what of what we're going to do, is the visual inspection of the shoulder. The why is so that we can assess normal anatomy of the bilateral shoulders, normal relationships between bony and soft tissues, and also to determine if there's any pathologies that are recognizable with the eyeball test, the EBT. Dr. Hoppenfield speaks to doing the shoulder assessment from behind. Having years of experience as an athletic trainer, I've found that I can miss too many things if I'm assessing from behind. It is more comfortable to do it from behind, and you can do it symmetrically. But when you do, I may ask an athlete, does this hurt or is it tender? And they'll say, no, it's just fine. And you won't get a valid measure. So I like to do things from in front. When we start this process, I'm going to drop down to eye level. The first thing we're looking for with the visual inspection is fluidity, symmetry, posture, proportion, color, contour, condition, and creases. With symmetry, again, we're looking for, are they symmetric? Symmetry, help me.
Symmetry.
Posture, proportion. Okay, the posture, we can do an anterior line of gravity or a lateral line of gravity, and we're also looking for the size. It gets a little questionable when we say consistency. What does that mean? That's like if there's a rash or dryness or seborrhea or psoriasis or scars. Hoppenfield refers to blebs, but I've still never figured out what that means. So you're looking for anything that's abnormal. Also, you're looking for contours. We have the deltopectoral groove, etc., and the traps and the sternocleidomastoid, the nice round deltoid. If it drops off, it tells you other things. So those are the things we're looking with a visual inspection. The shoulder girdle is actually referred to as three joints and one articulation. The joints are the sternoclavicular joint, the acromioclavicular joint, the glenohumeral joint, and then the articulation is not actually bone on bone like a diarthrodial joint with all of its relative structures, but the scapula, which takes the shape of the thorax, and it has the serratus anterior and the subscapularis coming around, attaching to the ribs and to the shoulder. So it's not bone on bone, it doesn't have a capsule, it doesn't have a synovial membrane, so it's not diarthrodial. We'll call it an articulation, as it's muscle gliding around on ribs and muscle. Very well. As your client first walks in, the first thing you're looking for is fluidity and symmetry. We will have this gentleman, if you would, please shed your shirt. As he does that, I'm looking if he uses both arms and if he compensates one movement over the other. Often when we have pain or change in function, we will compensate one movement in order to prevent that painful thing. So that's what you're looking for with fluidity. Truly, your eye at this point in your academic experience is quite well trained, even more than you realize, at recognizing when something is not right. And that's the first thing you'll pick up, is the fluidity. Once you see the fluidity is there or not, then you're going to go into symmetry, posture, proportion, etc., and start breaking it down. But it's a very organized technique. We want to consistently start medial and move lateral, and superior and move inferior. Just for consistency, so that you can check yourself and make sure you haven't missed anything. Before we start, there's a couple of conditions I wish to identify that Hoppenfield speaks to that you may recognize immediately without even looking for fluidity. One of them is called Erb's palsy. This is actually a contracture or a tightness or a tenderness, so they'll hold it, of the internal shoulder rotators. It makes, we go like this. It's called waiter's tip syndrome, Erb's palsy. A contracture of the internal rotators makes the arm lock out here. Well, they do lock it out, and the palm turns out like I'm asking you for a tip under the table. Waiter's tip or Erb's palsy. Another condition is Sprengel's deformity. I'm going to have you pivot this way without bumping your knees. In this case, the Sprengel's deformity, have I got the right one? I'm going to check the book. Sharman's, yes. Sprengel's deformity, the scapula descends down normally as the skeleton or the fetus matures down into this region. But sometimes the child is born and it hasn't descended completely. So the scapula, instead of the spine of the scapula being here, it will be clear up here. And that leads to a no neck. The skin, instead of coming down around like this, you'll have skin going from here to here because it's filled with the spine of the scapula. So it's what it is it rides high. Sprengel's deformity. This person will have a no neck because it's going from like the mastoid process clear out to the acromion process with the skin. Another condition that might be the same, present the same is, and it's not in Hoppenfield, is cervical rib syndrome. Rather than your ribs coming off the spinous process starting at the thoracic vertebrae, some people congenitally, and it may be genetic, their ribs come off of the last two, C6 and C7 spinous process, which necessitates then that the musculature in the skin comes out to the acromion process, just like Sprengel's deformity. This person is obstructed by the scapula or the ribs, cervical ribs, and so you'll notice that they kind of look like this, but really it's webbed here, and they have to rotate the trunk because they can't turn their head. There's bony obstruction. We had a classmate here, graduated a few years ago, that had that condition, and it was very obvious when you saw it. His was cervical rib syndrome. Another condition is Schauermann's disease. This is a kyphosis of a youngster. Usually, kyphosis occurs because of gravity pulling on the skeleton. Not always, but if you don't have a good posture, you have a slouch shoulder, 70 years of gravity being able to grab the shoulder and round it, or back pain, we tend to round the thoracic cage and the thoracic vertebrae. A youngster or a juvenile having this is quite abnormal, and we've given it a name, Schauermann's disease. Those are some conditions you might come across. One more is that you see how we have the clavicle and then the deltoid come off the inferior aspect, the anterior deltoid down to the deltoid tuberosity, middle deltoid, and posterior deltoid. And we have the greater tubercle of the tuberosity of the humerus, and the deltoids coming off cause a nice rounded shoulder. If you ever see the acromion, which is a flat bone right here, and it steps off straight, and you don't have this nice roundedness, that is indicative of a dislocated glenohumeral joint. It's called step-off sign because the acromion comes out and it steps right straight off. Those are some things you can spot immediately with the eyeball test. Having said that, I'm going to turn him towards me, and I'm going to be on the angle so that the glare here doesn't bother everybody too much there. We are going to test bilaterally. We are going to always start with cleansing our hands, and, which has been taken care of, cleansing our hands, doing introductions, asking for permission to touch specific parts and give a reason. Nate, may I have permission to look at and touch the bones and muscles of your shoulder in order to, 1, make sure the anatomy is normal, 2, check out relationships of bones and muscles, and 3, see if there's any change in function or pathology.
Yes.
You have all the power here. So my hands are clean. We are not masked up because he's already had COVID. I have no signs and symptoms. He has no signs or symptoms, and I've had the first shot. Also, it's important to me to be able to see the face of my client, because what they say and I hear may not be the whole truth, especially if it's an athlete, because they've paid such a price to play D1 ball. They may say, no, that doesn't hurt, because believe it or not, they truly love the practice and to be able to stay on the court or the field. So I want to see the countenance, and we're clear here of any signs or symptoms. With your permission then, I'm going to start with my visual inspection, and initially we're looking bilateral. We're going to start at the medial and superior, and I'm going to look at the surface anatomy is what we call it, looking for fluidity, symmetry, posture, proportion, color, condition, creases, contraction. And so the sternocleidomastoid is prominent. I'm going to have you, no, I'll do that with a soft tissue evaluation. If you look at him, I can see from here, have you ever sprained this joint here or broken this collarbone? Are you left-handed? You are left-handed. I see more dominance here on his left side than his right side. And honestly, the pecs are more developed, and he's more developed in the sternocleidomastoid, and to me that's apparent. This left clavicle is very dominant. Whenever you disrupt this joint or this joint, grade 1, 2, or 3, sternoclavicular, acromioclavicular, the clavicle serves as a strut. Envision your hands duct taped to your end of a pole vault, and you planted that pole down in the pit, and now you're trying to reach the pit with your foot, but your hands are taped to the pole and you can't get close enough. With the entire shoulder girdle, this articulation right here is the only contact the entire shoulder girdle has with the axial skeleton or the trunk. And so it serves as a strut. It maintains the relationship of everything as the scapula glides around the rib cage. Without that, I've seen pictures of people who don't have the clavicle. Right now, everybody, try to touch your shoulders together. And you can't because you've got this strut, which maintains relationship. There's a lot of pressure on that strut. So if you disrupt this spot or this spot to any degree, grade 1, 2, or 3 sprain, then because of the pressure, this usually rides high, superior, and anterior, and it'll be that way the rest of their life. Does it require surgery? Maybe if it's a grade 3, and or it will scar over if it affects their quality of life. But again, any disruption of the forces through here, and often landing on the outstretched hand or landing on the shoulder, the forces are all transmitted to here, and you may see the deformities there. I thought he had something here, but you can see this rides higher here than here. There's a big difference. In this case, I'd start doing a postural assessment, but that's not the purpose of this video. So, asked and answered, it's because it's his dominant arm over here. Do you have any pain in your arm or anywhere? Please report to me if I touch anywhere and it's uncomfortable or tender, okay? If I do anything that makes you uncomfortable, you stop me before you're uncomfortable, okay? You have all the power here, Nate. Very well. So we're looking at the sternocleidomastoid. Then it's natural to see this webbing here, the traps. The traps is a large muscle we'll talk about later that gives you this look right here. We have the medial 2/3 of the clavicle should be concave. It goes in the cave versus convex, medial 2/3. It is subcutaneous. Muscles only attach at the inferior and posterior aspect of the clavicle, so we do have a good visual. Medial 2/3 is convex, and then the lateral third is concave. Where it starts to be concave is an anatomical landmark. This is where the pectoralis major narrows down and dives under the anterior deltoid and ties into the greater tuberosity of the humerus. But it gives us this crease right here. This is called the deltopectoral groove. This is clinically significant because there's less tissues there, so if we need to access the shoulder for surgery, that's where we'll go, so we don't disrupt as many soft tissues. And it's also a landmark when we start doing bony palpation, which is another video, to locate other bony and soft tissue structures. So we're looking for those. The pecs, his right pecs is slightly more developed than his left, and yet his right pecs is more full through here than here. Have you ever had any problems or pain with your chest muscles?
I have not.
Remember, your client doesn't speak our medicine speak, so you gotta simplify. And he's more full here than here. In fact, the pectoralis major is the most common muscle that's congenitally missing parts or the whole at birth. That combined with the palmaris longus, the pecs, if parts or the whole thing may be missing at birth, and that's the most common muscle that is missing at birth. Does it affect your quality of life? It's a matter of degree, and he's not missing any here. Looking at the fullness here, the levels here, the mammillary line, we're looking at the rounded deltoid. I suspect you've not ever dislocated your shoulder, or it's not dislocated now.
Correct.
We'll talk about a sublux versus a dislocate later on. Having seen this, we want to look at where the deltoid ties in, the deltoid tuberosity, and then the biceps just medial to that, and look at the symmetry. We're also looking at creases. You say, why would we consider creases? Well, a person may have a youngster with their cute little Michelin man legs have these little pudgy rolls. And if the creases are symmetric, same in number, it's normal and they'll likely grow out of it. If they're different, then something's bending wrong or moving wrong, or there's not symmetry in the relationship of the tissues or the structure like we talked about initially. Having looked at this and we've named common conditions, let me have you, we're going to spin around, and let me have you stand if you would please. Now we're coming to the posterior view. We want to look at shoulder level. I anticipate, and it is the case, his left side is higher. Truth be known, with research we've done, usually if a shoulder is dropped, it's the dominant side that is dropped. So he's abnormal. And I don't know why, but he's not complaining any problems.
I throw and do everything right-handed, but I write and eat left-handed.
Ashton answered, and it confirms my statement. I like it when you do that. So he throws with the right side, and the research we've found is that the dominant side drops if one does drop. Doesn't mean you're going to have any related scoliosis. It just drops a little bit. You can see how much more full he is here. His power events are with the right arm. He writes in each with the left, but still, this is more full than the other. We can see the upper third of the traps. We can see where the deltoid tie in, and we can also see the lateral head of the triceps. Gives a nice look. Please straighten your arm out and lock it out. There's your lateral head of the triceps. And relax. We can also easily see the inferior angle of the scapula. The scapula runs from the second thoracic vertebrae down to the seventh thoracic vertebrae. We designate that in order to landmark and localize different vertebrae. Spine of the scapula, and I don't want to get into the bony too much, there's a flattened region right here where the spine of the scapula ties into the vertebral border. Vertebral border is usually 2 to 3 inches. It depends. On a petite person, you might have 2 fingers from the spine to the vertebral border. He's got 3. A big, broad-shouldered offensive lineman might have 4 or 5 fingers. We can see where the upper third of the traps ties into the spine. Underneath it, we're looking for symmetry. This is the infraspinatus that would be there. We can see the inferior angle. The superior angle is hidden under the traps and the levator scapulae, and it also dives anteriorly. We can look at the true AC joint, little knob here, while the clavicle goes from flat and rounds out here. There's still a little bit more round here, so you can see the prominence there, and check the level as well. Rhomboids come across here, but you have them superficially, the middle third of the traps, and then the traps come down to T12. We have the lats. That gives you the nice wing right here. Originates at the iliac crest and the lumbar fascia, wraps up and just barely crosses the inferior angle of the scapula, twists upon itself, wraps up through the armpit and ties into the floor of the bicipital groove. You want to look for consistency here. The lats are your adductors, A44. That's why swimmers always have the nice V look. And he's got a good strong V look right here. It's either shirt or scars or this chair. I see some scars across here. Scars. And so I've noticed, and I'm not going to ask you here on film, it's none of our business, but you don't just go through the motions and check off the box. If you see something which is visual now, you're going to ask about it, because it may affect other things. Very well. Let me have you turn around and sit down. And I'm going to fly through the book real quickly to see if there's anything. No, I won't. I'll just go ahead and see if there's anything else I wanted to cover that I missed. And again, I've mentioned to you to really highlight and mark up your textbook in order to be able to quickly fly through and see the things you want to see. And that's what we're going to represent for the visual inspection of the shoulder as per Hoppenfield. Thank you.